So let's get started. I'm going to introduce our first speaker, Simon Boulis, who is the owner of Live Well Pharmacies right here in our region, in Niagara. He is an excellent speaker, and he is an expert on hyperlipidemia, on cardiovascular disease, and this is what he's going to be speaking about today. So without further ado, let's start the program. Ladies and gentlemen, Simon.
Good morning, everyone, and welcome to our CE Sunday morning session. My name is Simon, and I'm thrilled to be here presenting for you today. So first, huge thanks to Pampi, Sean, and Nishan for organizing this fantastic event and for inviting me to speak today. Our session will explore secondary prevention in cardiovascular disease and how we as pharmacists can lead the charge to improve outcome through structured intervention. So in full transparency, I receive honoraria, grants, and research support, but today's session is grounded in evidence-based medicine, guidelines, and patient-first care. I have no commercial bias to disclose. Today, we will cover three big areas. First, how to identify very high and extreme risk patients, what the latest guidelines say about lipid target and treatment pathways, and finally, how to turn this into a pharmacy workflow. Think about one of your high-risk patients. By the end of this talk, you will know exactly what to do next for them. Okay, our first patient today, Mr. Smith. He is 72-year-old. He is a long-time patient on a blister pack, and he's coming for 6 months review of his medication. His medical history is type 2 diabetes, hypertension controlled. He got a stroke 5 years ago, and he did a angio, and his LAD stenosis is less than 50%. His lab works has his LDL, HDL, non-HDL, A1C, eGFR. Okay, he's also overweight, not active, and on a few of the medication. And this is, by the way, is not a rare case. This is many of our patients that we see every day in practice. So based on what you just seen of his medical history, what would you classify his cardiovascular risk? By show of hand, who guys of you think he is a high-risk patient? High? Very high risk? Okay. Extreme risk? Okay. Okay. Let's step back, look at how guidelines actually categorize the risk. So, this table shows to you the risk layers that we need to consider. Number one, ASCVD. That alone puts a patient at very high risk to very high risk. Okay, add to it diabetes, chronic kidney disease, recurrent event, polyvascular. Polyvascular, that means in 2 different vascular beds. That take that patient to extreme risk. Again, this is not just for lipid target. This is stratification. This is how we decide the therapy intensity. This is how we decide the follow-up frequency and actually access to advanced therapy like PCSK9 inhibitors. This decision tree is for treatment as well. It puts you the escalation guidelines and documentation risk and to justify your intervention. So let's look again. That patient is a definition of an extreme risk of cardiovascular. Let's meet another patient, younger, different profile. Mrs. Nassim. She is a new patient to your pharmacy. She walks in with a prescription, 45-year-old. She had a STEMI 10 months ago, and she got 2 stents at that point. Her LDL is 1.9. Her lipoprotein, little a, if anyone is familiar with, is 145, and she's actually on statin and on ezetimibe. Another real patient, but that is the unnoticed one. This is the one that we don't stop on that profile. What do you think her risk level is? So, show of hand, medium risk, high risk, very high risk. Okay, again, polyvascular, recurrent MI, acute within the last 12 months, it put them at actually very high risk. Her lipoprotein little a over the 120 can push her into an extreme. 49-year-old, only statin and ezetrol is actually very high, up to an extreme risk of another cardiovascular. So what are the target for those patients? And what medication are they on? This is a study of over 7,600 ACS patients. We found that 42% are actually above the threshold of treatment. 1 in 4 of them, their LDL is over 2.2. Sad fact is, only 50% of those patients are taking statin, 13% taking ezetimibe, and only 1% taking PCSK9. We assume our patients are controlled. We assume they are actually taking the right medication, and that is not really accurate, nor the same as being at target. Those patients need intervention. And why would I say that? So this is another study from Alberta. It followed 33,000 patients for over 3 years. Back to it, the first sad fact, over 50% of those patients, like slightly, 52% actually, and 30% with acute MI were taking statin. The rest were not taking any statin to start with. The risk, on the left side, the risk of experience a primary cardiovascular event, which is another MI, stroke, go to the hospital for a unstable angina or getting a revascularization, or unfortunately cardiovascular death. These 5 risks are way higher. When we put that very high risk or extreme classification, it actually jumps from 1 in 5 will have a recurrent event to 1 in 2. And when we are talking about cardiovascular death, 1 in 10 with ASCVD will experience cardiovascular death. It jumps from 1 in 10 to 1 in 4. Unfortunately, this is actually Mr. Smith, Mrs. Nassim, made this the right side of our presentation. And another thing, these actually outcomes are preventable. If we get their LDL to the threshold, we can change that trajectory. Just to deliver this message again, another study, this one is from the States, and it followed around 28,000 patients. You will see that almost 50% of those patients meet the definition of high risk or extreme. You will also see that that category has a higher risk, 3 times higher risk of getting another cardiovascular event versus the non-very high or extreme risk. And the worse it shows if they have 2 major events, a polyvascular event. Okay, what does the guidelines tell us to do? Those are the 3 top international guidelines, and they define the target in secondary prevention. In Europe, their target for LDL is less than 1.4. If you are extreme, it is less than 1 actually millimole per liter. In the States, they emphasize that intensified therapy, especially if it is 1.8 or over. Here in Canada, we use a different word. We use LDL thresholds. 1.8 or higher does not meet the threshold, so you want to be lower than that, and it doesn't matter when to stop. Also, in Canada, we encourage the combo therapy. So across the board, Europe, North America, we are no longer statin only. If you are not intensifying treatment, you are actually not guideline aligned. Okay, how do we reach those targets and recommendations? So your first step is high-intensity statin. Not just statin, it's high-intensity statin, and that's only rosuvastatin 20 or 40, or atorvastatin 40 and 80. That's step one. Step two, a little bit conditioned. So after the statin, if the LDL is still over 1.8, but less than 2.2, if they are not at very high risk or extreme risk, you add ezetimibe. But if it is over 2.2, if it is high, very high risk patient, or if that patient is with the statin, with the ezetrol, didn't meet the target, you add PCSK9 inhibitor for sure. Step four, you take a look at their triglyceride. If the triglyceride is between 1.5 and 5.6 and their LDL is controlled, you consider adding IPE, which is the Vascepa. Okay, why I put it in that way, and I will compare that to the next slide, is just to remove thinking too much about it. It's a plug and play, and all of those are safe evidence and backed with evidence. This is the CCS guidelines to follow. I actually have a hard time following this. So, and why are we recommending those specific medication with that specific step-by-step? According to big trials, landmark trials, we found that it doesn't just move the labs, it actually saves lives. Statin offer 20% relative risk reduction in ASCVD by dropping 1 millimole of LDL. If you add ezetimibe to a statin therapy, you're adding another 6% relative risk reduction to that patient. If you add evolocumab, Repatha, you're adding another 20% relative risk reduction compared to statin alone. If you, for those specific patients with uncontrolled triglyceride, you add IPE, you get another 25% reduction in their MACE event. Just imagine, and it's not an add, 1 + 1 = 2, but imagine you are adding layer and layer of cardiovascular protection to those patients. Okay, let's recap quickly. We start with statin. We escalate to PCSK9 inhibitor for extreme risk or uncontrolled. We also consider adding IPE. This is evidence-based, this is stepwise, and this is actually pharmacist-led recommendation. Okay, is it all medication? Actually not. This is actually what we are really good at. That changes that low risk, low cost, and it actually have a high impact on your patient. And every single one of those recommendations are strong with a very high quality of recommendation from every single guidelines. Mediterranean style, DASH, plant-based, fiber diet is a strong recommendation to all of your cardiovascular patients. Exercise with at least 150 minutes per week, moderate activity, even 20 minutes a day, 5 days a week will meet the criteria. Your weight aim is less than 25 BMI, or we are moving a little bit away now from the BMI because it's tricky. Waist circumference, less than 94 for male and less than 80 for women. And smoking. You just don't ask them if they are smoking or not. You need to offer them smoking cessation, nicotine replacement therapy. Alcohol intake is encouraged maximum 1 drink per woman and 2 drinks per man. These don't need to be fixed. This is in one visit. This is a plan and a follow-up we put it for our patient. So how we make this sustainable? Number one, you identify your patient. You run your report just from those two examples. You run a report with statin, with diabetic medication, with blood thinner. If one patient take all those medication, they are extreme risk off the bat. You also flag your walk-in patient, someone walking in with a hospital discharge, a prescription from a cardiologist, or when you're asking them, have you have any past medical history, and you just keep an eye for a stenting or angio. And when you do that, you book those patients for professional services appointment. You check their lab, you check the medication, the lifestyle, and you identify the care gaps. Now, our struggle usually in documentation, so I would recommend to use a form because we lack in this part, but you stratify the risk as we learn, you identify their target, and you make your recommendation to their primary care practice. And you build a service around this. This is, all those services are billable, they are scalable, and they actually improve the outcome. And this is not just good care, it's good business too. During the last 15 minutes, I'm talking about mid-review, follow-up, pharmacist opinion, smoking cessation, all are billable services. Every service can be packaged and offered to your patient. It is good clinical care, and it actually pays for itself. And it builds loyalty from your patient. When you improve someone's lipid, when you protect them from an event, they will not leave you. And you build a name and you build a reputation in the pharmacy business. Thank you so much.